I'm going to be the last speaker, so hopefully you still have lots of glutamate and dopamine in your brain for the last talk. And we are going to kind of wrap up the things that we have been discussing. I changed some of the slides to be able to follow some of the discussions that we had and be able to provide kind of further discussions about how technically neuroscience could provide inspirations for the process of addiction treatment. So we have been discussing about something like 5-6 topics that you are seeing here, a little bit about neuroscience of stimulant use disorder, and Kathleen Brady presented a beautiful presentation about what we know about potential treatments for stimulant use disorder, and as she has been discussing about the difference between cocaine and meth. And I'm going to make an exam from her talk. What was the difference between cocaine and meth? What are the things that you have in your mind about the difference between cocaine and meth? Short-acting, long-acting, yes. What else? Mechanistic are a little bit different. What are the other things? Response to treatment, that is good, yeah. I mean, they have different responses to treatment, right? What else? So we have been discussing that cocaine is mainly plant-based, shorter acting, and meth is a kind of longer acting medication or substance. And we already have a medication on the name of digoxin. That's basically meth for ADHD. And I already have kind of a few of them in my clinic, my ADHD clinic. So it is not very frequent to be prescribed, but there are already patients that they are receiving digoxin for the ADHD treatment. And we have a greater toxicity with meth. Why we have higher toxicity with meth? And how we potentially can prevent that? Why meth is more toxic than cocaine? Okay, so we'll discuss about that. So as I was discussing, it takes, I mean, when people use meth, it would be in the brain just after a few seconds. And so, as you can see here, even with PET, you can see that after a minute, 3 minutes, 5 minutes, the meth is there and is already active in the brain. For cocaine, it takes almost the same amount of time, but it clears faster from the brain. So this is something that you can see inside the brain. And then we know that cocaine is a dopamine reuptake inhibitor, right? Or dopamine transporter blocker, DAT, right? And also it has norepinephrine transporter blocking, right? What are the differences between Ritalin and cocaine? Okay, one important thing, just take a look into this figure. I mean, methylphenidate is, as you have been seeing here, is purely dopamine norepinephrine, but cocaine has a serotonergic component to it as well, okay? And the reality is the major difference is basically cocaine is really fast acting, and the fast acting effect of cocaine is the main driver for the addiction part. While methylphenidate, it takes time to go up, it is going to be there for a longer period of time, and we usually use very, very lower doses compared to what the dose people use for cocaine. But I mean, there are similarities, and you know there are studies that people show that basically those kids that are being prescribed with methylphenidate, in long follow-ups, they have not been able to show any major side effects of prescribing Ritalin in long term for people. And it seems that the speed of going up and the speed of going down, that is the major side of toxicity for most of the substances, okay? So when you do going up very fast, going down very fast, that is the major issue, whether it's in withdrawal or whether it's basically in intoxication. And then we have basically amphetamines. And what is the difference between amphetamine and Ritalin? What is the mechanistic difference? What do you see in this figure that was not there in Ritalin figure? So we have one new basically molecule here compared to the one that we saw before. In methylphenidate, that net, here we have VMAT as well. And what is VMAT? Stands for? Okay, so going back to the slide that I was discussing about dopamine synthesis. So we know we have dopamine receptors, we have dopamine transporters, and we have VMAT, which is vesicular monoamine transporter, which basically collects dopamine from synaptic space, basically presynaptic neurons, the cytoplasm there, and push them into vesicles, okay? So basically pushes dopamine into vesicles and then basically accumulate dopamine into the vesicles, okay? And when people are using meth, the interesting part is the action of vesicular monoamine transporter changes in a way that you have a diffusion of dopamine into presynaptic cytoplasm. So there is a huge amount of dopamine on the nerve end terminal, on the presynaptic terminal. And when you have accumulation of dopamine somewhere, dopamine basically starts to make reactive oxygen species or reactive oxygen radicals. And reactive oxygen species, they basically make neurotoxicity. So when you have accumulation of dopamine at the end of synaptic terminals, you will have neurotoxicity there. So the reason of neurotoxicity is just the accumulation of huge amount of dopamine on that terminal, okay? We have one other, there are a few other medications that they target VMAT. Have you heard about them? VMAT2 blockers. What are the medications that are VMAT2 blockers? Anybody has any memories about VMAT2 blockers? Have you heard about tetrabenazine, deutetrabenazine, valbenazine? What are the indications of these medications? For Huntington, right. One is Huntington. The other new application is tardive dyskinesia. And there are different, there are VMAT blockers. But MET is VMAT opener. So basically, it opens VMAT in a reverse direction and kind of releases dopamine to the synaptic level. So they have differences. But there are some other medications that they target VMAT. And the mechanism is the same. They reduce the availability of dopamine in the synaptic, dopaminic synaptic. And the mechanism, because we know that those who have tardive dyskinesia or those who have Huntington disease, they have more sensitivity to dopamine. So you reduce, VMAT blockers reduce dopamine. MET increases dopamine there. And then you have neurotoxicity because of the accumulation of dopamine, okay? And the reality is, the Adderall medication that we are already prescribing for people with ADHD, they basically have the same mechanism. And the reason that they are not neurotoxic, or they are not neurotoxic in the therapeutic dose that we use, is because we just give them really lower dose, and they basically go up very slowly and go down very slowly. And there is not enough of them to accumulate dopamine to a level of neurotoxicity, okay? So what they have the same mechanism. So if you use Adderall in a higher dose, very fast, injected or snort, that could do the same thing that methamphetamine is doing, okay? The mechanism is technically the same. And then basically having things like Vyvanse, Lisdex and amphetamine. So making them in a way that they are being absorbed from your GI tract slowly, because basically adding lysine amino acid to the whole molecule, and then they are being divided in two pieces inside the GI system and absorbed very slowly. They are released very slowly. So they would not go that high, and they would not make an accumulation of dopamine. Otherwise, they could be toxic as well. Does it make sense? So it's a sort of a message in terms of how these medications, if they are, and there was a question about illegal prescription of amphetamines, so they can technically do the same if they are out of the prescription and therapeutic dose that we are using. The other issue is about neuroscience of new psychoactive substances. And I basically picked up two major groups that I think are going to be important for us right now with the limited amount of time that we have. One of them is xylazine. So I think xylazine is definitely an important molecule to discuss about. And basically xylazine is being used as tranquilizer for large animals. When you see those kind of movies in the nature and there are darts that they basically use them, or there are specific kind of guns that they pushes a specific medication to the animal to just bring them down and kind of do any sort of intervention that they want to do, they are using xylazine. So it's being used for basically bringing down an elephant of 30 tons. So they are very, very strong. But now xylazine is being added to heroin and fentanyl almost everywhere in the US to just basically boost up the effect of fentanyl, okay? And I'm not sure whether that is being tested here in Mexico, and I can ask Hugo, have you heard about labs that are testing xylazine here in Mexico? You are testing xylazine? Okay, so that is a new trend in terms of, even in the US 5 years ago, that was not the case. So now people, in most of the states, there are testing xylazine, and it's kind of, it was supposed to be in just few states. Now everywhere in the US you can see xylazine, okay? What is the mechanism of action of xylazine? Have you heard about that? Anybody knows how xylazine works? What is the molecular pathway for xylazine? What do you guess? What could be the mechanism of xylazine? Any guesses? Like NMDA? What else? Could it be a benzodiazepine? Working on GABA, right? So there are, let's see what is the mechanism. Interestingly, it works on alpha-2 adrenoreceptors. So it is basically alpha-2 agonist. And what are the other alpha-2 agonists that you know? Clonidine, right? We know that clonidine has a sedative effect. If you prescribe clonidine, most of the time you like to have clonidine being prescribed in the nighttime because it could be sedative, okay? And then the other medication, dexmedetomidine. Have you heard about that? What is the application of that medication? UTI, no. For? Okay, so have you heard about IGALMI? IGALMI has basically received FDA approval recently, dexmedetomidine, and it's just a sublingual film for agitation in bipolar, and also in schizophrenia. In Alzheimer and bipolar, 1 and 2, okay? And also, as you can see here, schizophrenia. So the FDA approval, I think the FDA approval for the Alzheimer should be a new one, or it has not been cleared yet, but there is a study on Alzheimer as well. So IGALMI basically works on the same pathway in terms of having an agonistic effect on alpha-2 adrenoreceptors, okay? And these are, on that specific pathway, they can interestingly reduce alpha-2 agonists. They basically reduce the norepinephrine tone and modulate that in a way that when it is being combined with opioids, they could be kind of enhancing the effect of opioids. And the challenging part is when you have a patient who is overdosed on xylazine and fentanyl, then it is not going to be responsive to naloxone. So that is the challenge. Because, I can imagine alpha-2 kind of agonists, they are not responsive to naloxone. You still need to use naloxone, but the only thing that you can do is just basically putting them in ICU, doing supportive care to kind of make the drug clear from their body. And this is one of the studies that people show that, okay, this is the level of agitation, and when people are being prescribed with, I'm talking about IGALMI, and after 20 minutes, it could basically reduce the level of agitation. So that's being used for agitation. So now xylazine is being considered as a medical health kind of challenge, and the number of deaths because of xylazine is just rising up. The other interesting thing about xylazine, I'm not sure have you heard about that, kind of those people who are using xylazine, there are lots of reports of really bad-shaped wounds and kind of necrosis in their limbs. And it seems that because of the effect on the way that norepinephrine system works in the body, it could just make lots of constricture in the vasculature system and makes lots of ischemia and then ends up to necrosis in tissues. So there are lots of reports about basically having tissue necrosis because of silencing. Okay. So the other group that we need to discuss about very fast is just what they call HPSO, or highly potent synthetic opioids. Okay. For HPSOs, the cardinal one is fentanyl, but beyond fentanyl we have sufentanil, alfentanil, remifentanil, so there are lots of different fentanyls, and now there are some novel synthetic opioids in the same category. And interestingly, most of them are not very much bioavailable when you eat them, so they usually need to be injected or kind of being used as transdermal or transmucosal. And now the market, I mean, in the US is expanding. We know that there are challenges in China, there are challenges in Mexico, there are challenges in India. Now we can just discuss about how the global aspect of these HPSO medications are changing. And some of them are still not even being kind of illegal because they are recently being synthesized, so nobody knows about how they work. Why HPSOs are so potent? Why they are that potent? They have some specific characteristics. One of the characteristics is they are really highly lipophilic. So they can be dissolved in any kind of lipose tissue that you have in your body, and they can be accumulated there. So if people use, especially if people use multiple doses, there would be an accumulation of that in the body in a quality that it takes time to be cleared from the body. So if they go to, let's say, an overdose with HPSO, and when you give them naloxone, it works for a period of time, and then you have another level of HPSOs coming into the blood from lipose tissues. So you need to have multiple doses of naloxone over the time. Otherwise, they are not going to be responsive. So they work interestingly in a way that they just still stay in the body. And they are really highly efficacious on mu receptor. And nobody knows exactly why they are that much potent. I mean, a milligram of them would be able to kill a person. So how they can get that potent? And there are very, very limited studies on human participants, as you can imagine, because they are really hard to test. But interestingly, one really important clinical point is while they are really potent on mu receptors, buprenorphine still has a higher affinity compared to them. So when you have buprenorphine and fentanyl available, there would be a higher chance for buprenorphine to attach to mu receptors compared to fentanyl, which is interesting to see. So, I mean, and even compared to basically methadone. And you can see that basically these are what they call Ki numbers. So the lower the Ki number, the higher affinity. And buprenorphine is 0.2, fentanyl is 1.3, and basically methadone is 3.3. So the lower, so buprenorphine is has a very high level of affinity. It's not very potent, but it really likes to be attached to mu receptor. Okay, so how this is going to change the way that we are thinking about treatment for opioid use disorder? Okay, if you already have somebody who is a substance user, okay, and there is no treatment, and they are in withdrawal, okay, all the mu opioid receptors, MORs, mu opioid receptors, are available, and you have withdrawal, you have negative affect because of withdrawal. If you give them full mu agonist, like methadone, okay? So if you give them full mu agonist, that would basically help them to reduce the level of withdrawal, reduce the negative affect. So that is what we do with basically methadone induction. But basically, when there is full mu opioid, when you give people buprenorphine, what is happening? Buprenorphine can rapidly replace the full mu opioid agonists, and then buprenorphine, which is a partial agonist, is not as effective as full mu opioid receptor, full mu opioid agonist. When buprenorphine is being replaced, then you have what we call precipitated withdrawal, because you rapidly remove all opioid agonists and replace them with partial agonists that are not that much effective. So because it happens very fast, you start to have a significant level of withdrawal. This is what we call precipitated withdrawal when you start buprenorphine on somebody who is already on things like fentanyl. Okay? And because fentanyl is, as I told you, is very lipophilic, it stays there for a long period of time, it's hard to make people to get to withdrawal and clean them up completely and then start buprenorphine. So that is a challenge that people are facing for buprenorphine induction with HIPSOs. Okay? So what is the solution? The solution is what people call low dose induction, LDI. Sometimes, I mean, people before they have been using microdosing, but I mean, it's not really macro. We still use millidoses. It's not micro. So we call it low dose induction. For low dose induction, what we do, we usually start with lower doses of buprenorphine. I mean, when you do induction, usually with buprenorphine induction, you usually start with 2-4 milligrams to start, right? Because that is the dose that you start. For low dose induction, we usually start with 0.5 milligrams. So really lower dose, and we gradually go up. And meanwhile, interestingly, we even do not put people in withdrawal. People are still under influence of full mu opioid agonists. How? As an example, they are on methadone and you are going to transfer them to buprenorphine. They are still taking their methadone. Or people are on fentanyl, and we cannot, let's say, ask them, okay, bring your fentanyl to the clinic and just use fentanyl while I'm doing the induction, but you can change their medication from fentanyl to morphine. They are still receiving morphine. They are still under influence of full opioid agonists. And then you gradually, step by step, replace those receptors one by one by partial agonists, which is buprenorphine. And over several days, basically reduce the opioid agonists as well. And then at the end of the day, you end up with just buprenorphine without any full mu agonist. This is called LDI. So we do it very slowly in a way to make sure that this is going to happen. Okay? So that was the idea of LDI based on what we know about neuroscience. This is how neuroscience basically shape our understanding in terms of how to do induction in the era of HIPSO. Okay, few last slides. Few other things that you definitely need to know. As I was discussing, things changes over the time when people are using substances like heroin or opioids. In the later stages, people have challenges in the level of stress management, especially in amygdala. That is something that I was discussing before. How this works, basically. In your brain, you have a system that responds reasonably well to stress. And you know it's basically your hypothalamus, pituitary, adrenal axis, right? CRH, ACTH, cortisol. That is the axis that works. When you have chronic opioid use, the challenge is the level of CRF production just changes in a way that your brain responds differently in your amygdala. And then if you want to do the treatment, you need to think about those factors as well. So how to manage that specific pathway and how we can optimize that. Okay, so how medications for OUD in HIPSO era are going to be a little bit different. One, if you have an overdose case and you are prescribing them with naloxone, you might need 15 plus doses over the time because they are very lipophilic, and they are being secreted from your lipid tissues gradually over time. So you need to do it multiple doses over the time. If they are not responding to buprenorphine, if they have lots of buprenorphine induction withdrawal, then methadone might be. I mean, we know that even from the past, we knew that those who have really high level of severity for heroin dependency, buprenorphine might not be the best option for them, and methadone could be potentially a better option. But if you want to go for methadone, then the doses might be 140, 160. So you might need to have higher doses. If you are thinking about injecting naltrexone for these people, it's going to be more complex because you need to make sure that they would go to a reasonable level of withdrawal, otherwise you cannot inject. And also, for the maintenance of that, if you do injection every 4 weeks, you probably need to do it every 3 weeks, every 2 weeks, because the need is higher. And you potentially need to do higher monitoring, or you might even end up, if it's not working, end up to prescribing them with methadone. And last point in this kind of the era of opioid receptors. So today we have been discussing about mu opioid receptors, right? We also have 2 other opioid receptors that we definitely need to know about. One is delta opioid receptor, and the other is kappa opioid receptor, okay? So mu opioid was euphoria, blocking that with naltrexone, blocking that with naloxone. So that was the euphoria part. Delta is more anxiolytic. And then kappa has a totally different function. How? Basically, a higher level of kappa would give you dysphoria and stress. And interestingly, many of opioid agonists and hypsos, they also have kappa agonistic action. And because of that, while they give you euphoria, they can make you anxious. They can make you feel bad. But you still continue doing that because of the mu part and the reinforcement part. And this is basically the kappa one works on the glutamate side. The mu one works on the GABA side. The GABA side, basically opioid, mu suppresses gamma. GABA was suppressing dopamine. When you suppress GABA, then the dopamine goes up, right? So the enemy of my enemy is my friend, so that is the way. I mean, GABA was suppressing dopamine, you suppress GABA, and then dopamine goes up. That is the way that basically mu works. But kappa basically suppresses glutamate, and glutamate was stimulating dopamine to increase dopamine. So when you suppress glutamate there, then the dopamine goes down. That is the mechanism that kappa receptors are working. Interestingly, buprenorphine has some kappa antagonistic function. And that might be the reason that people with buprenorphine, they report better profile for mood and anxiety disorder. It seems that buprenorphine is a little bit helpful in that process. And with the same idea, basically people started to develop specific medications that are kappa antagonists for mood disorders. And you will hear about many of those medications in the future. The aticaprant is the one that is probably in 2025, there would be kind of regulatory meetings about, and there are some positive results in terms of they can help for anhedonia, they can be helpful for so it's quite interesting to see how those pieces are actually working together. Okay. There are still many innovative targets that we haven't discussed about. There are interesting other molecules that could be targeted. And these logos are the companies that are working on different targets. And lots of exciting things to discuss about. I will give you an overview about that. The last point is just the idea of, as we have been discussing, but I was discussing the last point of discussion here for the next 2 minutes, discussing about the idea of biotyping. What does it mean, biotyping, in terms of when we have people basically in the field of psychiatry, how we might be able to cluster them. Let's say if we have people with alcohol use disorder, can we divide them into few clusters and then optimize their medications based on those clusters? And this is something that people are working on, trying to use different domains of brain function, negative valence, positive valence, cognitive system, social processes, arousal, and dividing people based on these main domains of brain function. One of those things that people realize is very important is the positive valence and negative valence. If you have euphoria, if you have anxiety, I mean, these two sides. And people show that basically, this is what we call pharmacophenomics, in terms of those who are, for example, using alcohol because of just feeling good, or those who are drinking alcohol because of just reducing the level of anxiety. So based on the phenomics of people, we can optimize their pharmacotherapy. Two key figures in this field, Karl Mann, Katie Witkowitz, they showed some initial results that potentially we have two groups of reward drinkers versus relief drinkers, and they have different mechanism of actions. Reward drinkers, nucleus accumbens, opioid system. Relief drinkers, the stress part, the glutamate part, those pieces. And there are even inventories of differentiating two groups. Those who are drinking to have fun, compared to those who are drinking because they feel hopeless. So they could be differentiated. And interestingly, there are pieces of evidence that people who have more relief drinking features, they might be responding better to acamprosate because of its effect on glutamatergic system, as we have been discussing, and those who are reward drinkers, they might be responding better to naltrexone. There are always controversies as well in these areas. Okay. Now, I'm basically concluding and wrapping up. The last thing that I really like to discuss about is just making sure whatever we are discussing about neuroscience, we will be able to communicate that with our patients. Because many of the things that we have been discussing today, I think that they are going to be important for our patients. If they know those details, they can be a part of the treatment process, part of the treatment team. And I really like what Christos was mentioning about prehabilitation and engaging patients in terms of getting them prepared for kind of alcohol withdrawal syndrome, and then doing kind of other things for them in the next step. That is a critical point in terms of when you provide education, how toxicity happens in your brain, how you can prevent that, how withdrawal is going to be. All those education are going to be important. For doing that, we started a specific initiative we called BARI, Brain Awareness for Recovery Initiative. And we developed materials basically discussing about these domains of brain function, like feeling bad or feeling good, okay? All those kind of, and then the things that people can do when they feel bad, when the things can do when they feel good. We developed different characters, the feminine version, male version, different types of cartoons, and different even races. And now they are publicly available. So if you scan the QR code, those posters are available. And now they are being translated to 22 different languages. So the Spanish version is available, so they can download the Spanish version. The Portuguese version is also available. And they are available in 22 other languages. And that is the hope that they have in terms of how we can basically change the future of addiction medicine. Those who are interested to know more about innovations in addiction treatment, we have a specific meeting in Hamburg on May 25th, 2025, discussing about all those innovations in addiction treatment. Is a part of the pre-conference event of ISAM 2025, International Society for Addiction Medicine, which basically Alex Baldacchino was the immediate past president, Kathleen Brady was a past president, Mark Potenza is the president-elect, so we have the entire crew here, and hopefully that is going to be an exciting event in Hamburg. And there's a website there. We discuss about multiple domains of innovations for addiction, from digital therapeutics, pharmacological intervention, biotechnology, virtual reality, integrated, all those different levels of innovation. And that is going to be a fun meeting. So this is the kind of the QR code for my slides. Those who want to have my slides, they can have the QR code. We discussed about excitotoxicity, glutamate, dopamine. We discussed about some of the new psychoactive substances, xylazine, hypso, partial agonist, buprenorphine, fentanyl, how they work together. We discussed about neuroscience can inform treatment selection, biotyping, naltrexone for reward drinkers, acamprosate for relief drinkers, new molecular targets. There are definitely some circuit-based targets, as Kathleen Brady was mentioning, using TMS, or Mark was mentioning, using neuromodulation for addiction treatment. It's always also about the psychosocial intervention. So it's not only about medication, psychosocial interventions, and also neuroscience-informed psychoeducation. So there are definitely lots of opportunities in this field. Hopefully those who are interested, they can join us in the field of really exciting things that are happening in innovations for addiction treatment within the next 20 years. So I'm really hopeful I will be able to be in the field for the next 30 years to see how all those innovations are going to change the strategy. And when we are back here in 20 years, we will have lots of other exciting things discussing about the innovations that are happening and the better treatments that we can provide for our patients. Thank you very much for your attention.